So we're turning to our AKI portion of this next two talks with myself and the person following me, Dr. Bihorik. We're turning to our AKI prevention portion of our talk. And the reason for that is because, as the slides are coming up here, many people aren't quite aware that we have about 50% of patients in the ICUs who develop AKI. So in the United States, if we have about 5.7, 5.8 million ICU admissions a year, that means we have about 3 to 3.5 million cases of AKI per year in the United States. So it's probably the most common thing that we run into in general in the ICU. We don't have half our patients with shock in the ICU, for example. So I think that it's very important that we talk about strategies that we can consider using to maybe start to decrease the burden of AKI, given the tremendous impact that AKI has on survival in the ICU. So first, I have a couple of disclosures that you should be aware of. I have done some consulting work in the field of AKI. I'm currently doing some research in AKI and intra-abdominal hypertension, as well as CRRT. And my wife is an Emory faculty member, and she has no conflicts of interest as well. A couple of disclaimers. Opinions and debates on these topics, especially fluid management, have been raging for decades. I'm not sure I'm going to be able to fully answer those for you. We had a similar session a couple of years ago, but thankfully there's been some more data that can maybe help inform our decisions a little bit more. I also want to say that I have stolen a quote that our plenary speaker before noon, Dr. Ely, likes to use, which is that a long habit of not thinking a thing wrong gives it the superficial appearance of being correct. And I think that is very apropos to fluid management in the ICU. And so data has begun to challenge some of our assumptions and dogma that we've had for a long time. So at the end of this talk, I want you to be able to describe some of the differences between isotonic crystalloids. At least if I accomplish that, then we've accomplished something. Describe some studies comparing isotonic crystalloids for acute fluid resuscitation and understand the need to individualize fluid selection. And that's, I think, the other big goal. So let me just start with a quick case, a typical case that all of us have seen. 57-year-old female with hypertension, hyperlipidemia, comes into the emergency department altered. She's found febrile, tachycardic, tachypnic, hypotensive, hypoxic. She has crackles in her bases and pyuria is noted. Her chest x-ray has infiltrates. Her cap refill is brisk, and she appears septic for all intents and purposes. Her lactate is 5.7. Her creatinine is 1.7 already. So this patient probably needs some fluid resuscitation or needs some sort of resuscitation. So I ask you, what is the next step in management of the patient? And I'm not going to poll you here, but these are the sort of selections that people oftentimes come up with, which is they either start norepinephrine right away. Some people give 3 liters of normal saline. Some people would give a liter of 5% albumin. Some people would give plasmolite. Some people would insert a central line and measure CVP or some other things to help guide therapy. So there's a lot of potential options that people sort of lean towards. All right, so the other thing I want to point out is that one of the other things that we have increasingly been talking a lot about in fluid management in the ICU is the idea that patients need to be thought about in terms of the phases of their critical illness. And so during this rescue phase, we're generally volume resuscitating patients. And increasingly, we're recognizing that we really do need to level this off because there's far too many patients whose volume status just continues to incrementally increase the entire time they're in the ICU. And that definitely portends poor prognosis. So if we level off, we really should be leveling off and then eventually de-escalating or de-resuscitating our patients. I'm not going to talk about this and the data that supports all this today. We're going to focus a lot on the rescue or resuscitation phases of our critical illness. So IV fluids are the most common drug we use in the ICU, okay? I call it a drug because like a regular drug, there really is a proper correct fluid or medication that we should use in an individualized approach. There's a proper dose or amount that we should use, and there's a proper timing or frequency, frequency of administration, timing of administration, and all of these are properties that define drugs. And just to show you how common this is, I really should update this for the most recent years, but you can see that Emory Healthcare purchases an insanely large amount of IV fluids. These are just the let me go back. These are just the 1 liter bags of fluids. I don't even include in here the 500 cc bags of fluids. And we're not in the habit of stockpiling IV fluids for a rainy day. So most of these are being used. So we prescribe a tremendous amount of IV fluids in all aspects of medicine. And everyone in this group knows that there are obviously two general uses for IV fluids. The first is volume resuscitation and boluses. And for the most part, we're pretty good about being fairly discreet with this. Bolusing until we feel there's no longer a benefit and then stopping. We also oftentimes use maintenance fluids on patients. And what I would like to argue, and again, I'm not going to talk so much about this, is that we are far, far too liberal with how we're using maintenance fluids, okay? That these really should be targeted fluids in high-risk patients who have high ongoing and or predictable losses. But far too often, it's indiscriminate and way too much. So show of hands, how many people in this room have realized that they've gone home from the ICU on a given day and not have anything to eat or drink for the entire shift? Okay, that's most of the people in this room. So essentially, you've been NPO for 12 hours, right? Have any of you gone into renal failure or died by being NPO for 12 hours? I'm sorry. I'm sorry. But the point is that just because your patient has a procedure scheduled later in the day doesn't mean that they're going to suddenly up and die on you in the ICU by not getting some sort of 125 or 150 mLs an hour of seawater infused into them, okay? So, all right, so what IV fluid do we use? I show these pictures because they're generally different. Gatorade is a balanced crystalloid, right? It has a little bit of everything in it, whereas sodium chloride is purely sodium chloride. All right, now, we're not going to get into a big debate about colloids versus crystalloids because I fairly agree with the literature that there really is no demonstrable difference in mortality for using colloids in volume resuscitation in almost all clinical situations. And I really find it fascinating that we continue to get these trials funded, given that we have yet to show any sort of positive effect. And I will just say that hydroxyethyl starches, in my opinion, are definitely nephrotoxic, even the newer generations, which some people argue are not. So their use has fallen way out of favor. Now, I want to just show quick 3 cases for demonstration purposes, because I am not kidding you, saw these 3 cases in the same week at Grady. Okay, the first was a 48-year-old male came in with septic shock, fairly obvious with these sorts of labs that everyone sort of commonly. And then there was a 45-year-old female who had had abdominal pain and vomiting for a week and had these labs, and a 76-year-old female from a nursing home resident, hypotensive and altered with these labs. So everyone's hypotensive, they're all volume depleted, they all need volume resuscitation. Can we really use the same drug to treat all 3 of these patients? No, they don't have the same problem, so we can't use the same drug. So what are our choices then? So we all know normal saline. It has 154 milliequivalents of sodium, 154 milliequivalents of chloride. Most people don't realize the pH is 5.4, so they're not getting some sort of quasi-expansion acidosis. They're getting an acidosis because you're infusing acid into them. Sodium bicarb, if it's mixed with 3 amps in a liter, depending on what you mix it in, whether it's dextrose or sterile water, has an osmolarity of about 3 and a pH of about 8. And there's no reason why you can't bolus sodium bicarbonate. Why people run it over, 100 cc's an hour for 10 hours, I don't quite understand. You can run it as a bolus. The problem is that it has to come from pharmacy, so it's not really very useful if someone's like hypotensive directly in front of you. All right, balanced crystalloids. So there's a whole group of things called balanced crystalloids. And we call them balanced crystalloids because they look a lot more like your serum. They've got a little bit of everything, and they don't have nearly as much chloride in them, and so they're not considered hyperchloremic solutions. There's LR and something called plasmolite A, which are by far the 2 most common in the United States. Their pHs are more normal. Hartmann solution is available in the rest of the world, not really available in the United States. There's something called plasmolite 148, which has just a skosh of hydrochloric acid in it to bring the pH back down. I'm not entirely sure why people think that that's a good thing. And then Normasol R looks a lot like plasmolite A as well. Now, the important thing I do like to point out here is that they all have a little bit of potassium in them. But we have to be realistic. It's 4 to 5 milliequivalents of potassium, which means that you need to give 4 to 5 liters to give 20 milliequivalents of potassium. I, as a nephrologist, can't stand here and honestly tell you that I worry about 20 milliequivalents of potassium going into a patient when total body water is also being diluted by an additional 4 or 5 liters, unless the patient already has like a sine wave EKG or something like that. So I wouldn't worry about that. And I can tell you that I don't think I've ever clinically seen any significant increase in potassium from massive resuscitation with balanced crystalloids. Okay, so just turning to some data points really quickly, I just want to show you 2 older studies that looked at healthy volunteers and gave them balanced crystalloid versus normal saline and just watched and see what happened, okay? But the key point here is this portion of the data, which is that everyone's weight goes up 2 liters, but when they get the balanced crystalloid, their weight comes back down to normal much faster, suggesting that they're able to excrete the balanced crystalloid much faster. And that was shown here, which is that it took over 3 hours for these healthy people to urinate after giving 2 liters of normal saline, where it only took an hour for them to urinate after having balanced crystalloid. Who has ever not exercised and had 32 ounces of Gatorade? All right, almost everyone in this room would need to go to the bathroom within about an hour after drinking 32 ounces of Gatorade because it's a huge balanced crystalloid and it's going to stimulate a lot of urine output. Not a good idea to get it when you get on the highway to start driving someplace. They did this study about 10 years later and did exactly the same thing with plasmolite instead of Hartmann's solution. And you can see the same thing, that the weight fell more quickly when they got the plasmolite. But here was a really interesting thing in this study, which was that they put everyone in the MRI machine and measured their renal blood flow while they were giving the fluid. And they actually showed that paradoxically, renal perfusion went down as they were getting the normal saline, probably as a result of hemodynamic renal arterial manifestations of the high chloride content, juxtaglomerular feedback and other things like that. Whereas renal perfusion stayed the same or maybe went up a little bit when they got the plasmolite. So turning to actual patients, there was a large retrospective study done of surgery patients who need resuscitation, comparing people who only got one versus the other on the day of surgery. And they showed that while a lot of things don't necessarily meet statistical significance, there is a strong trend to fewer complications postoperatively when they got balanced crystalloids. And there was a whole heck of a lot less resource utilization in the hospital when they got balanced crystalloids compared to normal saline. Taking this forward to more prospective studies, a large ICU in Australia, did a crossover study where for 6 months they could only use high chloride solutions, and then for the next 6 months they could only use normal chloride solutions, and they showed that there was a decreased rate of more advanced renal failure during the intervention period when they had balanced crystalloid resuscitations, and there was a small but significant difference in dialysis. Not that this makes a huge clinical difference, but I guarantee you that makes a cost difference in your hospital for the amount of dialysis you're doing. Now, what's new since the last time I spoke on this topic at this forum is that we've now had a lot of studies that there's starting to be some meta-analysis and some other new studies. So this is what I really want to point out. If we compare mortality studies, both randomized controlled trials, observation trials, there is no real hugely statistically significant sign here that there is a mortality difference between these solutions. However, I do want to point out that every one of these studies, the summary point does fall on the side of favoring balanced crystalloids, that we don't have any study points that are saying that potentially they favor high chloride containing solutions. When we look at renal failure, this trend is a little bit stronger for renal failure and does reach statistical significance. And for blood transfusions, there are certainly appears to be a trend towards fewer blood transfusions in patients who get balanced crystalloid resuscitations. How much does a unit of blood cost your hospital? Do you know? About $800 to $1,000 from the Red Cross, depending on your contract. So this is expensive. Now, there's been a couple of other studies that have come out that are not included in these meta-analysis, which is a large retrospective study in sepsis that showed that as the percent of balanced crystalloid goes up that was used in the first 2 days, the risk of death goes down. And this held true whether you got a little bit of fluid or a lot of fluid. if you were exposed to balanced crystalloids within the first 2 days, you did better compared to patients who were not in this trial. Now, many of you are going to correctly point out to me that there was this very large randomized controlled trial that was done called the SPLIT trial. How many people have read this trial? All right. I might have a little bit different view on this trial, and I will take you through this. This, I want to first off say, was a fantastically designed trial, okay, as far as critical care trials go. It was a prospective, blinded, cluster randomized, double crossover study in 4 large ICUs in New Zealand, comparing balanced crystalloids to normal saline. They were marked solution A and solution B, and we'll talk about what that meant. And this was all patients in the ICU that were receiving crystalloid therapy, and the only people who were excluded were people who already had AKI or end-stage renal disease, basically, okay, because that was their primary endpoint. Now, what they did basically was that the ICUs were randomized to either fluid A or fluid B, and every 7 weeks they would cross over and start using the other study, and if somebody came in during one arm, they stayed on that solution so that patients never crossed over, and the ICUs had no idea what the solutions were with fluid A or fluid B. Okay? So it was really, really very well done. The treating clinicians could use open-label solution if there was a clear indication. Like a patient I showed you that was severely hypochloremic, they could get fluid, but there was no other restriction. So it was an extremely well-done trial. And what it showed, these are just the baseline characteristics of the patients. And, you know, the point of this is that the headline was that there was no difference. Okay? But I do want to just point out a couple of things of this trial, which I think is why this trial fails, and we shouldn't be looking at the headline of this trial. First of all, almost all of a large majority of these patients came from the operating room after elective surgeries. Okay? There was only a minority of patients who had non-operative admission diagnosis, and the operative admissions were mostly cardiovascular and some GI. The other thing I want to point out is that the mean duration of time in the ICU was only 1.5 days, which should make us question how sick these patients were. There was also only about 2/3 of the patients on the vent, and the mechanical ventilator hours mean was only 15 hours. Now, this does not necessarily comport to most of the patients I have in my ICU in terms of severity of illness. So I would make the argument that these patients were not particularly severely ill. So they don't have particularly high risk for AKI. The next thing is that they didn't actually get that much fluid. In the first day for their resuscitation, the mean was only 1.7 liters of fluid. Okay? So they essentially designed a fantastic trial that in the end enrolled a whole bunch of non-sick patients who did not have high risk for AKI, and they applied an intervention that might have a low amount of toxicity in a minimal amount of intervention. Okay? So essentially, these groups aren't any different, and they weren't going to have significant rates of AKI to start with. And so I think this is where this trial really sort of falls flat and really can't be trusted. So in conclusion, the authors wrote in the article that no significant difference in the primary outcome of incidence of AKI within 90 days, and therefore they made the argument that patients should have, you know, basically whatever they want. I say this is a low exposure of intravenous fluids in general, low severity of illness, and no report of renal biomarkers, which is what Dr. Bohoric is going to talk about. And so my conclusion is that in this well-designed trial, there was no demonstrable risk when used in small quantities to critically ill patients at low risk for AKI. However, I cannot make any conclusions regarding the safety of 0.9% sodium chloride when used in large quantities in high-risk patients. Okay? So in conclusion, I would like to say that IV fluids are a medication. You really need to tailor the therapy to the patient, and you need to be discreet with how much you want to give. That, in my opinion, hyperchloremic solutions do appear to have detrimental effects, and that balanced crystalloids really should be strongly considered for large volume resuscitations such as shock, DKA, volume depletion, and other high-risk patients and critically ill patients. And just to finish up, I'm not sure why. I'm going to ask if there are any questions, but I want to leave you with 2 ICU truisms. The first is save the kidney to save the patient, and the second is P to be free of the ICU. All right? Which thankfully comes from Anthony up there. All right. And you can contact me anytime.